Okay, my presentation is how to adopt evidence-based medicine in Africa, or I'll say low to middle income countries. So we just talked about what evidence-based medicine is. What we all tend to think is about just the data that is generated, and that constitutes application of evidence-based medicine. But I just wanted everybody to know there's more to that. It includes the local circumstances, the patient's choice, and the clinician's expertise, and the role of multidisciplinary treatment in the coming up with the best decision for the patients, most of all based on context. And also the fact that most of us in low to middle income countries don't have all the facilities that are incorporated into most data that is generated for evidence. So how do we adapt that to our situation? That was the main thing. And also we also looked at reasons why we might not be able to develop our own evidence, or why the evidence out there might not be applicable to Africa. So I think just to say that the evidence out there has to be balanced out with the economic realities of where you are and your patient's values and the society values as well, in light of the current evidence that we have in cancer treatments. Basically, that's what it was. I think that the impact is huge. It has the potential to be huge. What we really tend to fight against is the promotion of guidelines from high-income countries. Not that they are the ones forcing us to adopt them, but actually our young oncologists actually think that that is the best thing to do, to adopt evidence from outside and directly apply to where you are. But it really doesn't fit the scenario. It really doesn't. And what we're trying to improve is to get people to do more thinking and think about patient-centeredness and then the financial toxicity without even adding any extra benefits to the patient's outcome. So I think this is highly impactful. Guess that the dissemination is what might be a little bit difficult, but there's a movement everywhere, and this has to be pushed across all the African regions because we in low to middle income countries actually need this intervention more than anybody else. So I think the impact is big. Now is everybody's now in an app that can go onto the phone to remind you about the things you should consider before you make a decision on a patient. That's why I also tend to talk about resource stratified guidelines, how you're able to take a guideline internationally, examine your portfolio, what you have, and what you do if it was your mother or your sister because they live in the situation where you are, and see what is best for the patient. I think an app is something that would help a lot to apply this more easily across, because what our residents and trainees have is the textbooks, or the big textbooks online, and they don't really think about all these things. So I think an app will be something that will help them to be able to decipher and say, this might not work for my patient, this is the other option. So to discuss all options with the patients and give them a time to listen and to feedback before you make your decision, based on the evidence. Because some new treatments really don't add that much. They add just a couple of weeks, a couple of months. They tend to be significant, but significant for people who can afford that kind of money or who have capabilities of managing those kind of toxicities with us, or have rehabilitation centers. Unfortunately, we don't. So it's something that we really need to think about. Because this woman, most of the workers in Africa are actually non-formal. And some of these treatments might prevent them from going to do their work, might erode their capital, and they are not functional in their families anymore. So we really need to sit down and think about choosing wisely in how we manage our patients.